Welcome to our fifth edition of EBNEO Journal Club. Today, we're going to be talking about prediction models for infants with HIE, or hypoxic-ischemic encephalopathy. And I'm happy to Atul Malhotra from Monash University in Australia is joining us. I'd like to start with this post, which is highlighted here, that we posted at the end of March on a study that examined a model to be able to predict long-term outcomes with infants with HIE, which we'll get into later in this journal club. But first, I'd like to talk a little bit about prediction models. Now, what is a prediction model? It's taking a series of inputs. Here we think of these as variables or predictors, and seeing how these inputs or predictors associate with a particular outcome. For example, death or long-term disability. And based on these inputs, a model, for example, logistic regression model, can assign an equation that relates those inputs to the probability of an outcome. And that equation can be used to generate the predicted probability of an event. And once we have the probability of an individual infant's probability of an outcome, we can then generate measures of model performance, such as discrimination and calibration. So let's start with discrimination. Discrimination is the ability of a model, or another term is classification, to separate two groups of patients, those with and without an outcome. And in this example here, you can see the area under the receiver operator curve of 0.5. That's essentially a diagonal line on the right. And that's because the predicted probability of two groups of patients essentially overlaps. And so there's no separation of these two groups. And this is essentially a model that doesn't work well, but as good as the flip of a coin. The next example here is a model with an AUC of 0.7. Now you can see the distribution of the probabilities of these two groups of patients does start to separate, but there's this middle overlap where there's some misclassification. And that misclassification leads to a lower AUC, but you can see that there's this improvement in this model being able to separate these two patients based on their predicted probabilities. And that's shown on the right on the curve. And this last example is a model that perfectly separates two groups of patients into those with and without an event. You can see that by those two separate curves that are separated almost completely by the threshold probability of around 0.5. And that goes along with perfect discrimination and an AUC of 1.0, which you see on the right. These are very uncommon, but this would be a perfect prediction model. So now that we have an idea of evaluating both model performance by discrimination, the other piece of it that's important is calibration. How well does the predicted probability of a model match up with the observed proportion of events? It's a classic paper by Doug Altman and colleagues at the BMJ that looks at a calibration plot that shows that the calibration is off, that the predicted probability and what's observed are different. And that's important because if your model predicts an infant to have a probability of an event of 65%, but their probability is 90%, you'd want to know that. And so that's important to consider as well. So I hope that that's helpful. We'd like to do these EBNEO lessons as part of our journal clubs, but now let's get into the actual study. And so Atul, I'd like to bring you in here and tell us a little bit more about what this study found.
Thanks, Ravi. Yeah, so Eric Peeples and colleagues earlier this year in pediatrics published this study where they looked at retrospective data from the Children's Hospital Neonatal Consortium in the US. And they looked at their outcomes, primary outcome of death or neurodisability. So they had a huge number of retrospective cases which were entered into the database, but they could only include 28% of those babies. So close to 486 babies were included in the study. For the rest of them, they did not have enough data to include. And what they used was, obviously this is not a clinical trial, so they used real world data. They looked at simple outcomes like what was their condition at birth or condition at admission to the neonatal unit, and then how the baby kind of performed during the stay in the nursery when it came to either severity of HIE or MRI. One of the things I want to highlight here is the MRI markers they used was simple MRI markers, and I presume that was because many of the centers included in this consortium may not have had high grade facilities to either conduct MRS or actually look at MRI scans in a very robust manner like would have happened in a clinical trial, for example. So then they input all these risk factors which could have played a part in the baby's outcome and produced predictive models of two kinds. One was a predictive model or equation where they input all the characteristics at early age of the child, or soon after birth at admission to the nursery, and the second one was at the time of discharge from the nursery, to be able to predict that bad outcome or adverse outcome of death or neurodisability.
So thanks for that summary, Atul. I wonder if you can talk a little bit about kind of their approach in terms of deriving this model and also validating this model.
Yeah, so how they derived the model was that they input all those risk factors happening in the early neonatal period, like condition of the baby at birth or condition of the baby at admission to the nursery. And they use those risk factors to generate odds ratio and then the equation for the predictive modeling for the outcome of death or neurodisability. How did the modeling was they used 80% of their data to produce the equation or the modeling, and then they validated that the models on 20% of that rest of the data. Now this was a random selection of the data. There are many ways you can do validation of a model. The best possible way is an external validation where you are actually using that predictive modeling on a data which is not part of your own database, or you can do a temporal validation, which is the next best, where you generate the model on a particular data which you have and then apply that model on the next set of data over the next few years, for example. In this case, they were applying the validation on the same cohort of data which they had.
And you make a nice point about kind of the need for validation of these models, because often, because of issues of the model fitting the data very closely on which you derive it, when you try it out in a separate patient, it can perform very differently. So I appreciate your point. So I wonder if you could talk a little bit about kind of the role, when you look at these two models, about kind of the and we're going to pull up here the kind of AUCs from the early and the late model.
Yeah, so if you look at what various parameters they had used to generate the early predictive model, and as you can see from that early predictive model, the heaviest odds ratio we are seeing was the severity of the grade of HIE. So obviously a baby who is fitting or baby who is moribund obviously had much worse prediction of death or neurodisability. How this model performed as compared to the later model or the cumulative clinical predictor model was actually quite impressive. So if you look at the area under the curve for the early model, it's 0.852. And when they added the cumulative clinical predictors, that curve increases very modestly to 0.861. So that means that it was performing, the early model was performing almost as good as the late model. There was some improvement, but I won't say that that is a very high degree of improvement.
Why did you think MRI didn't add much? Do you think it was something about this being just a binary measure?
Yeah, it's an interesting question. So if you look at clinical trials and all the other predictive models which are present for therapeutic hypothermia and HIE outcomes, MRI focuses or features heavily on those papers and meta-analyses. And I think that comes down due to the fact that the trials or the big centers running those big trials have a heavy focus on imaging. They have very good expertise on not only running those MRIs, but also analyzing those MRIs.
So, when we think about models, there's often a desire to include lots of variables, but the addition of each variable might have additional cost in terms of either the clinician having to try to find this data or an additional test such as EEG or MRI. And I wonder if you could speak to that, and this ties a little bit to your conversation, through Twitter with Brian King about kind of the trade-off between maybe additional predictors, but the cost that those might incur.
Yeah, it's a good question. So there are two sides of the coin in that with every predictor which you add, you might improve the predictive model, but at the same time, that comes at a cost. And the cost might be that you need to do an extra test, which might cost money, resources, time, and other factors. And also it might add stress for the family. This study highlights that very nicely, that sometimes those imaging or EEG or some other parameter might not be the only thing which you need to focus on. And I think a holistic model like this helps in kind of teasing out that.
Thank you for joining, and thank you all for listening. Please subscribe below if you enjoy our EBNEO Journal Clubs. This is our 5th one, and we'll have our next one coming in the next couple of months. And thank you for watching.